problem. My name is Dr. Tobias Otieno, as you have been informed. I'm giving a talk on fingertip injuries. These are the small things that we often ignore, that you take lightly. It's a typical thing that a consultant sends a medical officer to take care of. But I think after this, I hope that most of us will have a change of view in terms of how these injuries ought to be taken care of. Okay, so just a brief overview of the anatomy of the tip of the finger. We are concerned with the injuries that occur distal to the attachment of the flexor digitorum longus, or rather profundus, and extensor digitorum. So flexor digitorum profundus and the extensor digitorum longus insertion. So if you look at the screen, the tendons are the two items that are, two structures attached, both the dorsal and the volar aspect of the proximal end of the distal phalanx. So injuries that occur distal to that point are considered fingertip injuries by definition. And I want you to just take note of the important anatomical structures. So the structures on the nail. So the nail eponychium, the paronychium, and of course the hyponychium, and the nail plate. And of course the matrix, both the germinal and the sterile matrix of the nail. And I want you to also appreciate the septation of the fat pad at the tip of the nail, because that's a very important anatomical arrangement that allows you then to be able to provide coverage for distal finger injuries. Just as an introduction, this injury occurs commonly in children, and it's typically due to door crash injuries. So a child sticks their finger either in the door hinges or a door slams against a child's hand while holding the door frame. In adults, these injuries can occur either as lacerations from sharp objects or as part of crash injury around the fingertip. The typical history that you would take is you want to know what's the mechanism of the injury. Was it a crash injury? Was it a laceration? Was it a bite? All those injuries have significant implication on the care. You want to know the environment. Where were you? Were you in the farm? Were you in the office? Duration since injury, and of course whether or not tetanus vaccination is up to date. And comorbidities, a significant contributor or decider in terms of what are your reconstructive options. Does the patient have diabetes? Do they have distal vascular disorders? Okay, is there any smoking history that could limit your reconstructive options? And on examination, you want to know the status of the wound, the orientation of the wound laceration, and neurovascular status, tissue loss if any, and the orientation of the tissue loss, because then that has implication on what reconstructive procedures you can carry out, regardless of the size of soft tissue loss. Viability, if any, of attached tissue distal to the point of injury, and of course, whether there's involvement of the nail plate, the bone, the tendon. Okay, and when we say nail, we mean all the nail and its components. So you're talking about the eponychium, the paronychium, the hyponychium, and of course the nail plate and the germinal matrix. Okay, those have implications on your reconstruction. Radiology, of course, you want to know the extent of involvement of bone. The X-ray before you, you can see that the middle finger has the tip chopped off, and it's missing, some bone. It's missing soft tissue. Okay, and it's important for you to, put that into consideration as well as you plan your treatment. A little bit on classification. It's amazing. We classify everything in orthopedics, and for good reasons. One, it provides us with a basis to decide on what treatment plan is. Two, we are also able to assess outcome based on severity of injury. And so the classification that I find easier for fingertip injuries is one that was designed by Allen. So Allen type 1, type 2, type 3, type 4. And type 1, of course, where the injury is barely involving the pulp only. And then type 2, pulp and nail bed. Type 3, distal phalanx fracture with pulp and nail bed involvement. And then further on, when the lanula, the distal phalanx, and the pulp and nail bed are also involved, that's a type 4. So again, the pictures highlights the level of injury, type 1, type 2, type 3, type 4. And those have implications on what reconstructive options you can actually employ to achieve healing. What is the treatment goal? One, arrest hemorrhage. The typical child will be brought by the mother, and sometimes the mother and the baby are all crying. The mother is crying because her child is losing blood, the baby is in pain, okay? And the first step is arrest hemorrhage, okay? And of course, minimize pain. If you want to also shorten healing time, preserve sensation, the fingertip is endowed with special sensory organs, okay? That are able to tell, between very precise to precisely within a very precise range on touch. There of course preservation of length and function, prevention of painful neuromas, avoidance and limiting nail deformity, minimization of time lost from work, and provision of an acceptable, cosmetic appearance. So those are your treatment goals. How do you treat pain? Either use of adequate analgesia, and sometimes in the casualty setting, this might be difficult. The painkillers, whether delivered parenterally, may take time to kick in. And what I find very useful is just a quick digital block in casualty, very easy to do with just your lignocaine. And after that, you have significant pain control. And that also brings with it benefits, okay? Because once you achieve analgesia on the fingertip, okay, the child is no longer fighting, the mother is calm, you can then be able to actually apply adequate pressure, okay, on the fingertip, okay, to be able to control bleeding and achieve hemostasis. In terms of surgical care of this injury, adequate debridement ought to be done under digital block in cooperative patients. So in patients who are able to withstand a digital blockade and be able to cooperate through the reconstructive process. So digital block is adequate. And in some, of course, nerve blocks, okay, depending again on what else you're dealing with. General anesthesia for patients, for children, or in uncooperative patients. And then, of course, tourniquet is required. You can either do this on the digit, so using just a simple glove, piece of glove clamped on with a hemostat is actually sufficient to control bleeding on a finger. And then, of course, after procedure, you can apply pressure dressing. For some, you may actually, if you may actually use, a 4M10 tourniquet, but that's a bit of an overshot. And then, of course, after reconstruction, limb splintage will control pain and allow healing to take place without the finger, moving too much. Okay. Just some of the examples of fingertip injuries. So in this case, it's just a hematoma under the nail plate. The problem is, such hematoma will cause pain, okay? And if the pain is manageable and the hematoma is not spreading beyond, 50% level, it's suggested that you can actually treat conservatively with just painkillers and leave the plate attached. But if the hematoma is progressively increasing in size, you're advised to perforate the nail plate, okay? And so this acts more like a decompression for the nail plate and prevents, further separation of the nail plate from the underlying matrix. You also relieve pain significantly. It's more like compartment syndrome under the nail. What you do, you decompress compartment syndrome, and that allows the tissue underneath to be under less pressure, to be vascularized, and of course, with it, you control pain. Nail should be, if the nail is advanced or has significant damage on it, and there's contamination underneath, you're advised to actually pull off the nail, okay? So that you can do a thorough surgical toilet on the bed. That also allows you to repair whatever injury has occurred on the matrix, on the nail folds as well, okay? So removing the nail plates that has been severely damaged allows you to be able to do repair underneath. And you're advised that, sorry to go back again, once the nail plate is actually removed, it is washed, thoroughly, and it can actually be implanted back. Note that, it will grow, but this provides a dressing for the wound, but also ensures that the eponychium, okay, does not scar down to the underlying tissue, and therefore preventing the nail from emerging from underneath, okay? So nail that is avulsed is either implanted, washed and implanted, or two, alternative material can actually be used to create the same thing, okay? So in this case, the picture on your right is a patient who had complete nail avulsion, had significant laceration on the fingertip following a crash injury, and the nail plate was avulsed, was severely contaminated, and bed was damaged. So we removed the nail plate, okay, but the nail plate was actually missing. So what we did is we reconstructed it using a foil, and so aluminum foil or artificial nail. The other is a cut out piece of plastic, maybe from the syringe, can actually be inserted under the eponychium. And what this does is it separates the eponychium from the underlying tissue and prevent it from scarring. Okay, where the nail plate is used, a window can actually be made on the nail plate to allow for discharge of material from underneath, so that infection then does not accumulate, and to provide some let out for material that accumulates on the nail. So that's my prosthetic nail plates made of foil. This foil is basically your typical Vicryl suture is packed in a foil. So if the foil is sterile, you can just use it as it is. But if it's not sterile, then you can actually carry out a cold sterilization of the foil and reimplant it. So you insert it under cut it to trim and fit the nail, and then slide it under the eponychium, and therefore preventing it from collapsing back and fusing. So typically type 1 injuries, as mentioned earlier, this is where the skin loss is minimal. And so it's considered minor, and dressing alone is actually sufficient to allow this to heal by secondary intention. But where there is a large defect, a full thickness skin graft can actually be harvested and be applied to the defect. The only challenge is that may actually not be cosmetically as pleasant as the other options that we'll mention later. So we talk about VY plasty, and especially if you can use the volar skin from the same finger. When reconstructing the picture of this child here who was brought in having sustained a crash injury. The dog, compressed her, crushed her finger, cutting off the fingertip. In this case, then, a lot more reconstructive work needs to be instituted to restore anatomy and reconstruct the fingertip. And the number of options that one can use. The cup technique. This is where you just, if you have the piece that came off, you can actually deskeletonize it. So remove the piece of bone, from it. If it's cut off with a piece of bone, remove bone, and then reimplant it as a cup over the distal end of the proximal fragment of the phalanx. It's said to be especially useful in children, and is said to have up to about 50% success rate. The only challenge is, once, if it fails, what you do? Again, you need to figure out how to reconstruct the fingertip then. Other options are local flaps, regional flaps, revision amputation, and of course, reimplantation, the last option. The reimplantation, I think, we leave to the plastic and microvascular surgeons. I think we'll focus more on the easier reconstructive surgical procedures. The cup technique have remained, as I mentioned, just the skeletonize the distal stump, and then reimplant it, suture it back over the wound, and it's said to have 50% success rate in children. In adults, the failure rate is a lot high. Local flaps, there are many options that you can actually use for local flaps. So tissue from the same injured finger and adjacent to the wound. So the tissue then replaces lost tissue similar to it. The one that I find very handy is the VY plasty, also called the Artesoy flap. Very easy to fashion. And then of course its variations such as the lateral VY plasty, where you actually release skin from either side of the finger stump and advance it to cover the fingertip. Then of course the homodigital island flap, also in my opinion reconstructible. I mean, if you understand the anatomy of the finger and understand that the neurovascular structures basically run on the lateral border of the finger. So you should be able to release a finger flap. I mean a flap, okay, with its vascular supply. So what the example here is what we call a volar VY plasty, or the Artesoy flap. It's best for transverse or dorsal oblique wounds. Distal ends of flap can move actually up to about a centimeter. You can actually advance this 1 centimeter to cover the fingertip. It's not good for volar oblique wounds. So when the wound orientation is volar oblique, it may not be very good because then it doesn't reach too far. If the wound is too proximal, then you may actually have difficulty with coverage. To do this, the nail bed and bone need to be trimmed to level up so that there's a bit of soft tissue over the bone, and the flap then sits over the soft tissue to provide skin coverage. Incision made sparingly, so just make a very superficial incision that just allows the skin to tag onto the underlying septae. So the septae underneath is what anchors the skin, and of course with it, it carries the vascular supply underneath. You can see that we have a defect here. We have made a V cut that's apexed proximally, okay, and then pull that over, and as you pull it to cover the soft tissue defect, then the Y arm of the flap is then sutured to provide coverage. Advantages of this flap, it's what I would call your typical fingertip workhorse. It's simple to perform. The scar is minimum and less painful since it's not located directly over the end of the finger. It's cosmetically excellent, and with good fingertip, contour and padding, preserves normal sensation of the fingertip because it carries the nerves as well. When you're releasing it, what you cut is just barely the skin, and then advance it with its safety attached. This can also be constructed from either side of the fingertip. So what we call the lateral VY flaps. So one from the radial and the one from the ulnar border of the fingertip. And so these then, meet in the middle as shown in the picture and provide coverage of the fingertip just, under the nail bed. Neurovascular advancement flap. This is where you actually release the flap together with its blood vessel and nerve, okay? And then flex the finger so that then the length of the flap is able to reach the fingertip and provide coverage as shown in the picture below. If you understand very well that the anatomy of the finger is that, the neurovascular structures actually run around or along the finger border where the volar skin interfaces with the dorsal skin. And so you can actually be able to release that with this blood supply and use it to cover large defects, especially on fingertip. The thumb is a good one to actually cover with this. Of course, the finger will be flexed, but with exercises and with subsequent releases, and full thickness skin graft, the finger can actually be extended fully. That's an example of another flap, okay? What's called regional flap, the thinner flap. So the finger is actually flexed to be opposed to the thinner skin. And a fasciocutaneous, flap of the thinner skin is released and attached to the defect, suture to the defect. Within about 3 weeks or so, the flap is then released, and the flap will stick to its bed. The donor site is then grafted with a full thickness skin graft, and that should provide very good coverage of the fingertip. A cross finger flap that you can actually release skin from one finger, an adjacent finger, okay, and use it to cover defects on the injured finger, okay. So rectangular flap released from the dorsal skin overlying the middle phalanx of a finger and adjacent finger. And then, of course, sutured to the fingertip that is flexed over the dorsal defect. The defect, left is then, grafted the full thickness skin graft. So when releasing this, just make sure that the hinge of the flap is actually adjacent to the injured finger. It's very easy to do it the opposite way, and then of course you will not be able to, reach it, or you can reach it but not be able to take care of your donor site defect. While doing this, just make sure the extensor paratenon is preserved, and then of course full thickness is applied to the graft donor site. Other more complex flaps, heterodigital island flap, where a flap is actually released from a finger in the same hand and then advanced to cover defects on the adjacent finger, on the injured finger. Then of course distant flaps, where you actually use either axial, random, or a free vascularized flap. I think our domain will mostly within the axial and random flaps, and be able to provide coverage over the fingertip. That's an example of a source of an axial flap, deep superficial epigastric artery, superficial circumflex iliac. Those can actually be used to cover defects in the finger, but they're best where the defect is actually extensive. So where you have extensive involvement of the hand, that will be a bit more suitable. It's a bit of an overshot for a finger defect, unless of course you run short of local sources of flap. Then of course there are injuries that you may not be able to reconstruct, such as the type 4 and some of the type 3. it is okay to actually carry out an amputation because again, you may not have the capacity to carry out, microvascular surgeries, such as implantation. It's okay for you to actually just, revise the amputation, and and allow for healing to occur with that kind of stump. Distal phalange fractures a bit complicated, but typically due to crash injuries. The typical thing would be involvement of the bone and the soft tissue and nail, the nail. So again, the reconstructive process is based on what we've discussed up ahead. Just some of the examples that I have taken care of. The case one that I'm presenting is that of a child about, I think, a year or 2 years old, who sustained a crash injury to the finger, was brought into the casualty, and of course, the child was bleeding. You can see that, from this picture that the fingertip is actually amputated. It's most probably a type 1 or somewhere between 1 and 3. And the X-ray attached also shows the missing tissue on the fingertips. It's more of a type 2 injury, actually a type 2 injury. What we did is we took the child to theater and did surgical toilets, distal phalanx shortening, and an artery flap. And you can see the tissue has been advanced, okay, and is covering the fingertip with the defects. We had initially we doubted, whether this would survive, because if you look at the skin of the flap, it looks a bit dark compared to the skin of the rest of the finger. But after a month, this is the same finger that was injured to the middle finger. You can see the scar along which the suture line was actually made. And when you look at the same finger, you can hardly notice, a difference. So the child was healed. We achieved, cosmesis. We restored function, and the mother was very satisfied. And as you can see from the photo, her nails tell you how she values her daughter's nail. And so we were able to give her a cosmetically and functionally acceptable reconstruction from an otherwise severe injury that she thought would end up with an amputation or at least an ugly reconstruction. Look at the fingertip. You can hardly tell that this was a finger that was injured before, the middle finger. Okay. Case number 2 is a gentleman again who sustained a crash injury to his fingertip. When he came, severely lacerated. The nail plate was missing. In surgery, we could not trace it. And of course, the point here is, however severely injured the soft tissue of the fingertip is, the anastomosis around the tip of the finger provides very good vascularization. So one should be very hesitant to debride off soft tissue from the fingertip. And you should try to, as much as possible, to repair. So of course, with the missing nail, we were able to repair the bed with the fine observable stitches. And because the nail was missing, we were able to fashion an aluminum, foil. So like a prosthesis made from aluminum foil, the typical one that is used to pack, Vicryl, cut it to shape and implanted it on the fingertip. Under the hyponychium. And so that then serves to separate the hyponychium from the underlying tissue and provides a pathway for the nail to emerge from underneath. So this was a picture taken about 2 weeks. We don't have I didn't take the initial pictures, but at 2 weeks, you can see that, there's, it doesn't look very pleasant, it doesn't look very nice. And one would be, would think that, this may not work. but look at the finger. You can't tell which finger it is between the two. This is about 8 months, post reconstruction. The fingertip is hardly, visible. You can see the index finger here. You can hardly see the scar, and of course the nail plate is, similar to the one on the opposite side. We achieved both length, we achieved cosmesis, and we preserved function. A very happy clients. Then of course there are those that you may not be able to reconstruct. It's acceptable to actually revise like some of the type 3 and type 4 injuries, unless you have capacity to perform microvascular surgery, which most of us will not have as orthopedic surgeons. Thank you.
All right, thank you, Dr. Tobias, for the wonderful presentation. We hardly discussed about the hand, but thank you for taking us through. So I'm looking out for any questions. You're able to access chat, Dr. Ri?
Yes.
All right, so I can see one from Prof. Lemma. What do we do if the injury involves the fingertip areas?
The fingerprint areas, is that correct? Fingerprints.
Mm-hmm.
I have provided solution for that, and by classifying them, and of course we can appreciate that for type 1, you just carry out dressing with non-sticky dressing material, or full thickness skin graft. For type 2, the reconstruction that I have highlighted above. The second question is, do you involve plastic surgeons? How many plastic surgeons do we have in the country? We have none in Kisumu. So I think by and large, we still have to provide that care with or without plastic surgeons. I'm pretty sure that even elsewhere, the number of plastic surgeons are few and may not be able to reach every corner of the country. Is that correct, Paris?
Yes, that's very true. Actually, for most of the limb surgeries we end up having, as an orthopedic surgeon, you end up having to be the one to do the reconstruction. Some of us have access to plastic surgeons very close by. So yeah, that's true.
Okay.
All right.